So, with everyone's permission, I'm starting with today's live now. Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet proudly stands as India's most relied upon digital platform, offering a multitude of ensuring services exclusively for the doctors. It is with great pride that Clarinet serves as a digital partner for this event. And the focus of today's session is anesthesia at high altitude. Now, I would like to invite Dr. Meenakshi Sundaram sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges including Theni and Stanley Medical College, Chennai. He is a former national vice president of Indian Society of Anesthesiologists and has held key positions including governing council member, president and state secretary of ISA Tamil Nadu state branch. Now sir, I would like to invite you to proceed with the session. Over to you sir.
Thank you, Clarinet. Good evening, and I welcome all the delegates attending this 41st webinar under the caption Puthukkottai Bhudhan, second edition. Our 40th webinar was conducted on 22 October under the topic Oxygen Therapy. The faculty were Dr. M. Srinath from Puducherry, Dr. Ijaz Ahmed from Mangalore, Karnataka, and Dr. Mohammed Riaz from Bangalore, Karnataka, moderated by Dr. S.A. Rajkumar from Tamil Nadu. So 3 states participated, Tamil Nadu, Karnataka, and Puducherry. And now this 41st webinar on anesthesia at high altitude. We were searching for people to talk on anesthesia at high altitude. Then we have located faculty from Manipur, because we thought these Nepal people are entitled to talk about anesthesia at high altitude. Same way for India, the Manipur Regional Institute of Medical Sciences, Manipur has come forward. And at the outset, I thank Dr. Gojan sir for providing a good platform and a faculty. And that here, the faculty is going to be 2 residents actually. 2 residents that Antony Xavier is one resident, and Dr. Jyolsna is another resident. They are senior residents. And Dr. Jyolsna, originally she is from Kerala. She has done her schooling and MBBS in Trivandrum, Kerala, and she has done MD anesthesiology at Regional Institute of Medical Sciences, Imphal, Manipur. And she happened to be a scientific session coordinator and anchor for simulation-based workshop and ISACON 2024. He is a facilitating member of BLS training, and she was assistant surgeon for a while in Community Health Center, Thrissur, and ESI dispensary. And her areas of interest are regional anesthesia, perioperative medicine, critical care medicine, and transplant anesthesia. But these are all very common things which every medical person will have. But this lady doctor has won the first prize in state level intermedical mono act competition. So individually also she will be acting, as a team also she will be acting, and she has won the first prize in state level intermedical drama competition. So she is good at drama as well as acting, and she has won 3rd prize in Kerala University of Health Sciences Interzone and South Zone meet. She has won first prize in Interbatch Festival in mono act competition again in Government Medical College, Trivandrum. She has won first prize in English debate. So now we can see her command over that English language. So she has won that in Interbatch Festival, and she has won 2nd prize in Thiruvadira competition. Trivandrum is a popular festival in Kerala, and she has won 2nd prize. And in addition to that, she is having an interest in traveling, cooking, and dancing. So she's a multi-talented lady doctor, now from Regional Institute of Medical Sciences, Manipur, Imphal. We welcome you, madam. It will be followed by Dr. Antony Xavier. Antony Xavier is a native of Kerala, and he has done his undergraduation in Kerala and post-graduation here as Dr.Jyolsna. And again, he is also a scientific session coordinator and anchor. And he has participated in simulation-based workshop as an anchor. And he was a speaker in World Anesthesia Day celebrations. And he is a trainer in ALS and BLS workshop. And he is the university topper in MD examination. He is a university topper, won the first rank, and he is the winner of the annual PG award session, and he has numerous publications. In addition, he is a good photographer. He has won the first prize in the state level competition, and the second prize in orchestra. He is a keyboard player. She's a dancer. He is a keyboard player, and during his second BBS, he was a batch representative. So naturally, his interest will be in travel and photography. And in addition, he is interested in teaching. That is what he is going to do now. So with these two senior residents, we have two professors. So the first professor will be Dr.Longjam Eshori, and Madam is a honorary secretary of Indian Society of Critical Care Medicine. She is a professor in Regional Institute of Medical Sciences, Imphal, Manipur, and she is the joint secretary of ISA Manipur State Branch. So she is playing an active role in critical care as well as anesthesia. And Madam is having more than 23 years of teaching experience. And Madam has published more than 20 theses in national and international indexed journals. In addition, as a professor, she has guided hundreds of students in formation of theses. And Madam is interested in gardening and travel, and she's interested in exploring new things. So today she is going to explore anesthesia at a high altitude. When these three people are there, we were searching for a good moderator who can govern all these people. So we have found out Dr. Gojan, who is a professor and head of the department, but he is a down-to-earth person. He used to talk to me very cordially, and every time he clarifies things then and there. And he has formulated his team for anesthesia and high altitude. At this juncture, I want to say I am attending national conferences for the past 25 years as a faculty. I have never seen this topic as a common topic in any of the conferences. So I think in the webinar also, even in Puthukkottai Bhudhan first edition, we have not hosted this topic. And Sir was kind enough to accept to do this anesthesia at high altitude. He is a professor and head of the Department of Regional Institute of Medical Sciences, Imphal, Manipur. And Sir is a treasurer of ISA Manipur State. He was the executive committee member, ISA Manipur State Branch. And he is having more than 28 years of teaching experience. And he has published more than 21 articles in national and international indexed journals. So because of his vast experience, he has again guided hundreds and hundreds of students in thesis writing. So Sir is interested in sports, mainly soccer and traveling. And all these four faculties are common hobby, one common hobby. All are interested in traveling, but they are settled in Manipur. I think they have to travel all over the India and bring glory to the Regional Institute of Medical Sciences, Imphal, Manipur. And I request Dr. Gojan sir to take over the scientific session. Please, sir.
Thank you very much, sir. And a very good evening to everyone and to all the delegates. The introductory topic will be given by Dr. Jyolsna MS, who is a senior resident in the Department of Anesthesiology, Regional Institute of Medical Sciences, Imphal. Please go ahead, Dr. Jyolsna. Sí, que no lo quemado.
Good evening, everybody. First of all, I would like to thank ISA Puthukkottai City Branch, Dr. Meenakshi Sundaram sir, and all other organizers. And I would also like to thank my respected head of the department, Professor Gajendra Rajkumar, for giving me this wonderful opportunity to speak in this webinar. So I'll be dealing mainly with the physiological adaptations and pathophysiological changes at high altitude. So high altitude presents a unique physiological issue because of reduced barometric pressure and oxygen. So what happens? Our human body has to undergo complex adaptations. Then only we can maintain the oxygen delivery as well as the metabolic functions. So all our systems undergo adaptations, include cardiovascular, respiratory, hematological, renal, and central nervous system. So we should understand all these mechanisms for the safe conduct of anesthesia. So in the next 10 minutes, we'll be mainly dealing with the levels of altitude, accommodation and acclimatization, systemic responses, as well as the altitude-related illnesses. So first, let's understand what are the levels of altitude. What is called high altitude? High altitude means, high altitude is again graded into high altitude, very high altitude, and extremely high altitude. So high altitude is height in meters above sea level, that is above 2,500 to 3,500 meters or 8,000 to 11,500 feet. So one of the most popular tourist attraction, Leh, which falls under high altitude because the altitude is almost 11,400 feet. Very high altitude. It means 3,500 to 5,500 meters or 11,500 to 18,000 feet. The most common pilgrimage center, Amarnath, falls under very high altitude. And extremely high altitude is greater than 5,500 meters or more than 18,000 feet. We know our Mount Everest falls under this category. So what happens at high altitude? There are some physiological changes. We know that the atmospheric pressure at sea level is 760 millimeter mercury. But the composition of oxygen is 21%. What happens when we ascend from sea level? The atmospheric pressure will start falling. So at 11,000 feet, the barometric pressure would be 510 millimeter of mercury, but the composition of the oxygen will still be 21%. So at sea level, if we put this value into the alveolar gas equation, we will get that the arterial oxygen content is 100. Whereas when we put this at high altitude, because the barometric pressure is dropping, the arterial oxygen content will reduce to 47. So as the barometric pressure falls, there will be hypoxia at the tissue level. So this table clearly shows that we are going up from sea level. As the altitude increases, the inspired oxygen concentration decreases, as well as the alveolar and the arterial concentration also decreases. So what are the physiological responses and how it is divided? So physiological responses are categorized into acute response as well as chronic response. Acute response is called as accommodation and chronic response is called as acclimatization. So what is accommodation? Accommodation means immediate adjustment. I said there are all the systems in our body will undergo changes. So immediate reflex adjustment of respiratory and cardiovascular system to this hypobaric hypoxia. This occurs within minutes to hours of ascent. So there will be different changes like hyperventilation, sympathetic stimulation, increased 2-3 DPG levels, and neurological effects. I'm not explaining this in detail now because we will be dealing with all these things in detail in the coming slides. So accommodation means it occurs within minutes to hours. Acclimatization, it's like a gradual long-term adaptation to hypobaric hypoxia. It develops over days to weeks. So there will be increased pulmonary artery pressure, increased lung diffusion capacity, polycythemia, urine alkalization, and increased tissue vascularity, and increase in levels of mitochondrial oxidative enzymes. So it occurs in days to weeks. We will see why these changes are happening in the coming slides. So let's go into the systemic adaptations. First is cardiovascular adaptation. So what happens? When we ascend or when a person is in high altitude, there will be increased sympathetic activity that will contribute to increase in heart rate. And how does it help? Increased heart rate will cause increased cardiac output. So there will be better oxygen delivery. And what happens to the blood pressure? Hypoxia can cause peripheral vasodilatation, but there is sympathetic activation that causes vasoconstriction. So blood pressure will remain slightly elevated for initial few days. So this increase in heart rate and increase in cardiac output are actually compensatory mechanism to improve the oxygen delivery. But what happens to the cardiac output later? It returns to normal in few weeks. Why? Because there is diuresis that will reduce the plasma volume, that will further reduce the preload, and that causes decrease in stroke volume. So cardiac output is contributed by both heart rate as well as stroke volume. So finally, it returns to normal in few weeks. But will this normalization of cardiac output, will it compromise the oxygen delivery? No, because by the time the kidneys will already start secreting erythropoietin and there will be more RBC, more hemoglobin that will favor oxygen delivery. So these are the changes of cardiovascular system. What happens to the respiratory system? Respiratory system, the minute ventilation will increase. So the respiratory rate as well as the tidal volume will increase. So when it increases, definitely the carbon dioxide level will come down and that will contribute to respiratory alkalosis. So it is cold up there. It's very, very hard to breathe. So we need more oxygen. So what happens? Increase in pulmonary oxygen diffusion capacity, increase in pulmonary capillary blood flow, increase in surface area of alveolar membrane. All these will contribute to better gas exchange. And because of hypoxia, pulmonary vessels will undergo vasoconstriction. So what happens? That will lead to increased pulmonary artery pressure. So that can cause right ventricular strain. And we know from our basic physiological classes that whenever there is hypocapnia, that is respiratory alkalosis, carbon dioxide is decreasing, there will be leftward shift of the oxygen dissociation curve. So later, what happens? There will be increased 2,3-DPG. That causes rightward shift of oxygen dissociation curve, hence more unloading of oxygen at the tissue level. But finally, the oxygen dissociation curve returns to its sea level position in a fully acclimatized individual. And something about chain stocks breathing. So it is a periodic breathing characterized by crescendo, decrescendo tidal volumes followed by a central apnea. Why does it happen? There is hypoxia. So hypoxia means decreased arterial oxygen concentration. So the peripheral chemoreceptors will detect this and that will increase the minute ventilation. And also there is hyperventilation that will cause decreased arterial carbon dioxide. So that will cause a transient cessation of central respiratory drive. But both these feedback will be lagged. So there is a temporary lag in central and peripheral chemoreceptor response. So that will cause oscillatory ventilation. In this video, you can clearly see the chain stop respiration where there is apnea, then there is periodic hyperventilation and oscillatory pattern of respiration. Next, coming to hematological changes. What happens to the hemoglobin? Initially, there is an increased plasma concentration. This is not due to the increase in hemoglobin per se. This is because of diuresis. There is plasma concentration that will cause increased hemoglobin. It appears to be like increased hemoglobin. What happens in a chronically acclimatized individual? There will be increased erythropoietin production. And all this will contribute to increased hematocrit, plasma viscosity, polycythemia. So this is important because this can cause thrombosis, right? So that is why we are concerned about this. And there is also increased platelet activation and suppression of naturally occurring anticoagulant, dampened fibrinolysis. So there is less clot lysis and pro-inflammatory markers are also increased. So this will lead to a pro-coagulant state. Now coming to the renal and endocrine changes. So what happens? Hypoxia induces diuresis. That's why we say when we go to high altitude, they tell you to stay there for initial 2-3 days, drink more water, drink more water. So it is because early diuresis is happening. Along with that, sodium is also getting lost. So your renin, your aldosterone, everything will come down. And the atrial natriuretic peptide is also contributing to sodium loss. So there is water loss along with sodium loss. And we already know that there is hyperventilation that will contribute to respiratory alkalosis. So to compensate for this, there is urinary bicarbonate excretion that will lower the blood pH, and that will further facilitate ventilatory acclimatization. And endocrine system, since there is activation of sympathetic stimulation, catecholamine level will increase, cortisol level will increase, but on prolonged exposure, partial desensitization will happen, and there will be decreased heart rate and chronotropic responses. Now, what happens to the cerebral function? As we ascend up, there can be sleep alteration, mood change, headache, there can be memory impairment. Finally, there can be loss of consciousness. This is not just important for our patients, it is also important for us as anesthesiologists. We need to be aware that our own mental performance, concentration, and judgment can also be affected because of this altitude changes. Now, cerebral spinal fluid changes. So this is saying like what happens, there is respiratory alkalosis. So the PCO2 levels in cerebrospinal fluid also will decrease. So the pH is increasing, that will inhibit central drive, and there will be transient hypoventilation. After that, there is a compensatory phase. The CSF will also export bicarbonate, just like the renal compensation. So pH returns towards normal. So ventilatory drive is restored. Finally, in chronic acclimatization, bicarbonate level is decreased, PaCO2 level is also decreased. So stable acid-base balance will happen. What happens to the cerebral blood flow? Hypoxia is a stimulant, so that will cause cerebral vasodilatation. So there is increased cerebral blood volume and ICP. CSF production will decrease and absorption will increase. Over a few days, CSF volume normalizes with partial adaptation of cerebral blood flow. But in susceptible individual, we should know that persistent CSF and ICP imbalance can contribute to acute mountain sickness. Gastrointestinal response, there can be anorexia, which is very common on ascent. Leptin reported levels vary. They can be increased, decreased, or unchanged. Then there is something called cholecystokinin. Their levels are often elevated, especially in people having anorexia. So there can be delayed gastric and emptying. Persons are more prone for aspiration. And weight loss, both fat and muscle mass decrease with prolonged exposure. There is increased basal metabolic rate. So these things has to be concerned, especially when we are dealing with patients in ICU with regards to nutrition. Now, a word about altitude sickness or altitude related illnesses. Mainly, there are three types: acute mountain sickness, high altitude pulmonary edema, and high altitude cerebral edema. So what happens? When there is hypoxemia, in brain, there will be vasodilatation that will increase the cerebral blood flow. That causes impaired autoregulation and overperfusion. So this causes vasogenic edema. Along with that, there is sympathetic activation. That will also cause endothelial activation and increase capillary permeability, which will contribute to high altitude cerebral edema. What happens in the lung? As we have already said, there is hypoxic pulmonary vasoconstriction, but this is not even, it is uneven. So this contributes to increased pulmonary artery pressure. There will be some areas of overperfusion. I said it is not even. So increase capillary pressure, that leads to capillary leak. Along with that, sympathetic activity also contributes to pulmonary venous constriction. So because of the capillary leak in lungs, it will contribute to high altitude pulmonary edema. So these are the symptoms. In patients having acute mountain sickness, there will be nausea, vomiting, fatigue, loss of appetite, insomnia. Whereas the one in high altitude cerebral edema, they will have hallucination, loss of consciousness, photophobia, ataxia, confusion. And high altitude pulmonary edema, patients will have shortness of breath, chest tightness, dry cough, congestion, swelling, and fainting. So take home messages: we need to understand the altitude physiology. It helps us anticipate altered responses to hypobaric hypoxia, anesthetic drugs, and ventilation. And we have already mentioned that acclimatization will modify all the cardiorespiratory dynamics. So we have to manage the perioperative period accordingly. And we should also recognize early signs of altitude illness. And we should know all these physiological adaptation. They are protective. So our anesthetic practice should never suppress this compensatory mechanism. It should only support them. These are my references. And in 1953, May 29, Edmund Hillary and Tenzing Norgay, they conquered Mount Everest. So it shows how their body has beautifully adapted to such harsh environment, just like we saw in the last 10 minutes. So it's not the mountain we conquer, but ourselves. Thank you.
Uh, thank you very much, Dr. Jyolsna. Like our next topic is anesthetic challenges and consideration in high altitude condition. In high altitude condition, this will be presented by Dr. Antony Xavier, who is a senior resident, it's a Department of Anesthesiology, Resident Institute of Medical Sciences, Imphal. Thank you. Please continue, Dr. Xavier.
Thank you, respected head of the department, Professor Gajendra Rajkumar sir, and Dr. Meenakshi Sundaram sir, and ISA Puthukkottai City branch for giving me this opportunity. So, Dr. Jyolsna has mentioned about the pathophysiological changes. So, with that knowledge, let's move on to the next topic, that is the anesthetic challenges and considerations in high altitude conditions. So these are the learning objectives. We'll be discussing the topic under these headings. Let's initially first see the anesthetic challenges. What are the problems related to the equipments, how to do the pre-op assessment, then regarding how to give the oxygen delivery, how to do the monitoring, and the effects of hypobaric hypoxia and other ventilation strategies. So anesthesia itself, it's a challenging field, as we all know. So being at a high altitude and providing anesthesia, it poses an extra risk or extra challenge. So let's see how these challenges happen. So it can be broadly divided into two. One is because of the pathophysiological changes, as mentioned before, that is induced by the high altitude. And next will be because of the variations in anesthesia resources and equipment functioning because of the high altitude. First, let's see what are the challenges due to the pathophysiological changes as a person goes from lower altitude to a higher altitude. So the very first thing is hypobaric hypoxia. So we all know the barometric pressure at sea level is 760 millimeters of mercury. As you ascend up, it gradually decreases in a non-linear fashion. But the FiO2 remains almost same as 21%. So the 21% of 760 mmHg. For an example, I have put here three settings. One is sea level, one is Johannesburg, that is located as 1,700 meter above the sea level, and one of the extreme situation, that is Mount Everest. So we can see that atmospheric pressure is 760 mmHg at sea level, and it reduces to 640 mmHg at 1,700 meter, and again it further reduces to 253 mmHg. So this is nothing but an extrapolation of the oxygen cascade. That is, oxygen cascade means how the partial pressure of oxygen reduces as it moves from the ambient air to the cellular level, all the way through the lung, blood, etc. So the 760 mmHg of ambient pressure contributes to a partial pressure of oxygen 160 mmHg at sea level. The same will be only 53 mmHg if you are at Mount Everest at 8,848 meters. Again, see, at arteriolar level, the partial pressure has reduced to 92 mmHg, and it reduces drastically to 26 mmHg at Mount Everest. And finally, when the oxygen reaches the mitochondria, the partial pressure reduces to 5 mmHg when we are at sea level. So we know the Pasteur point, that is a point below which anaerobic respiration or anaerobic metabolism ensues. that is less than 2 mmHg. So that is eventually reached as you go up. So that is called hypobaric hypoxia. That means because of decrease in the ambient pressure, there will be hypoxia at the tissue level. It's a type of hypoxic effects only. So what are the concerns because of this hypobaric hypoxia? So when you provide anesthesia, you have to give prolonged reoxygenation, and patient might require postoperative oxygen supplementation even up to 1 hour. And opioids, benzodiazepine, all these narcotic agents, sedatives, as we all know, they cause respiratory depression. So we have to avoid opioids, narcotics, other sedatives when you manage patients at a high altitude, because they will blunt the ventilatory drive. Second thing is hypothermia. So we all know, as you go up, when you go to Shimla or even Shillong, you feel very cold, like the ambient environment is very cold. So anesthesia itself induces hypothermia. So hypothermia will be compounded in high altitude conditions. Because of that, MAC of anesthetic agents will be lowered, and there can be irritability of the atrioventricular bundle, which can lead to arrhythmias like atrial fibrillation, ventricular fibrillation, etc. So we have to employ active warming. So in our place in Imphal, during winter, it's very cold. Temperature even drops down to 5 degrees Celsius. So we always provide warm IV fluids, and we use active warming for our patients. Otherwise, they will be shivering like anything, and hypothermia will be a problem. So we have to take care of that, give warm IV fluid, give warm mattresses, and use forced warming. And humidity is also a problem, because as you ascend up, the humidity decreases. So it's mandatory to use a HME filter while ventilating the patient. Next problem is risk of aspiration. Even I was also confused why there is a risk of aspiration as you go. It is because as altitude increases, there will be hypoxia. This hypoxia can suppress your parasympathetic activity, so the sympathetic system can overdominate. So this can lead to delay in the gastric emptying. And also, as you ascend up, the gases in the stomach, it can expand because of decrease in the ambient barometric pressure. So this can also lead to increase in the intragastric pressure and put the patient at the risk of aspiration. So aspiration prophylaxis is very essential while you are managing a patient at a very high altitude. Another problem is because of high venous pressure and hypothermia, the venous dilatation and increased capillary density, there is high chance of blood loss when you are operating a patient. And there can be more oozing from surgical wounds. So this has also to be addressed. And another risk is venous thromboembolism. So at very high altitude, because of hypoxia, it can trigger prothrombin factor 2, etc., which puts the patient in a hypercoagulable state. And also, there is hemoconcentration that also leads to a hypercoagulable. So altogether, the patient will be at risk of venous thromboembolism. So thromboprophylaxis is very important. And another potential problem is postoperative urinary retention. Again, it's because of the parasympathetic suppression and sympathetic overactivity. And you have to be aware of the altitude related illnesses, like the anesthesia provider needs to have familiarity with the entire spectrum of HAI as mentioned before. And all this HAI, it can compound the postoperative nausea vomiting. So we need to give a multimodal postoperative nausea vomiting prophylaxis. And let's see what are the cerebral effects. So the blood-brain barrier permeability will be increased, and cerebral blood flow will be increased because of hypobaric hypoxia. So this can lead to a delayed awakening from anesthesia, and we have to differentiate this cerebral changes from other CVAs. That also is a very important concern. In the cardiovascular system, there will be elevation in the pulmonary artery pressure because of hypoxic pulmonary vasoconstriction. And the systemic BP will be elevated because of sympathetic stimulation during the initial time of the ascent. And there will be exacerbation of pre-existing cardiovascular comorbidities. And when you ascend very rapidly from a lower altitude, there is risk of triggering of supraventricular and ventricular tachyarrhythmias. And there was a study where they found that 9 male coronary artery disease patients, they develop ECG or clinical signs at a very lower workload threshold at high altitudes. So we have to be very careful with dealing with cardiovascular comorbid patients at high altitudes. And also there is an increase in the right to left shunt fraction because in patients with a patent foramen ovale because of increase in right-sided pressure. And the congenital cyanotic heart disease patients are also at a higher risk. So if possible, if the availability is there, we can employ advanced cardiovascular monitoring devices, and it's better to give a goal-directed fluid therapy for this kind of patients. And also keep preservative lignocaine, amiodarone, defibrillators, all those things to manage the arrhythmias if we have such patients. And the heart rate also should be limited to around 70 to 80% of the ischemic threshold level of the patient. So indirectly what it says is tachycardia should be avoided under anesthesia. Now the respiratory changes. Patients with COPD, they can easily develop an exacerbation because of the hypobaric hypoxia. So the respiratory function should be optimized before you take up a patient for an OT, and we have to avoid hypercapnia. And the patients are at very high risk of pulmonary hypertension. Now coming to fluid management, as you ascend up, the high altitude exacerbates dehydration because of hyperventilation and renal water loss. So if you're going above 3,500 meters, the plasma volume decreases by about 3 to 5 ml per kg after the ascent. And this can even persist for about 3 to 4 months. So when you take up a patient who has not been that much acclimatized to OT, you have to keep this in mind. You have to adequately hydrate the patient. Otherwise, if you give a spinal anesthesia, there can be a sudden drop in BP. And we should also be prepared for any emergency to happen, like appropriate equipment should be ready, medications should be ready, and evacuation resources should be kept as a backup. And regarding evacuation, one thing to keep in mind is if any trapped air pockets are there in our body, for example, pneumothorax, pneumoperitoneum, or even some bubbles in the IV line, if you airlift a patient in a helicopter, there can again be a sudden drop in the ambient atmospheric pressure. So that will lead to expansion of all these airfield cavities, which can be detrimental. That completes the pathophysiological changes. Now moving on to the effects of anesthesia on the resources and equipments. First thing is, mostly these settings will be on remote locations where the resources are often limited. And just for our information, in 1993, the first case was operated at high altitude by Dr. Green in a Tibetan patient for clavicle surgery, and it was done at 14,000 feet. But unfortunately, it resulted in cardiopulmonary arrest. So there has been two consensus regarding this case. One reason could be because of overdose of the chloroform because of hyperventilation. At high altitude, the patients will be hyperventilating not because of hypoxia. Other reason could be because of less ambient pressure, the chloroform was not properly vaporized. So it led to decreased anesthesia levels and pain might have triggered a cardiac arrest. So continuing with the topic, regarding controlled ventilation. So when we manage a ventilator, it's better to have a ventilator which has altitude compensation software. Altitude compensation means the air in the ambient air in high altitude regions are less dense compared to sea level. So what happens is when the less dense air is used to ventilate the patient, the ventilator will overestimate the volume that is delivered. For example, you are setting tidal volume at 500 ml in each breath, but because of this low ambient pressure, the ventilator might be delivering only 400 ml. So ventilators with altitude compensation software will be better to be used in high altitudes. Or otherwise, what we can do is we can go for pressure control modes instead of volume control mode. And also when you ventilate, always try to maintain the partial pressure of carbon dioxide at the baseline value rather than keeping it at classical 35 to 45 mmHg. And also PaO2 also should be maintained at a lower level because at sea level, PaO2 is higher. So if you keep the patient ventilating at a higher PaO2, the acclimatization that has happened before ventilating, it will be lost. After you extubate the patient, again the patient will have to reacclimatize to the ambient PaO2. So always try to keep the PaO2 at a lower level. Then effect on the bobbin, again the same thing, the ambient air or the air will be less dense at high altitudes. So what happens is the bobbin will underread the flow rate. For example, if it is going at 4 liters per minute, the bobbin might be reading as 2 liters per minute. So there is a formula that we can employ to correct this variation that's mentioned here. Next is a very important and interesting topic. What is the effect on anesthesia vaporizer? So first thing that we have to keep on mind is the effect of anesthetic agent, inhalation anesthetic agent, depends on the partial pressure of the volatile agent, not the concentration. So let's see here an example. At sea level, the ambient pressure is 760 mmHg. So I'm keeping sevoflurane at a dial setting of 2. So at 2%, how much partial pressure it is going to generate? 2% of 760 mmHg. That is 15.2 mmHg. This will give you 1 Mach of anesthesia. Now I am ascending to an altitude of 5,000 feet, where the partial ambient pressure is only 380 mmHg. That is half of sea level. Now I am keeping the same dial setting of 2%. So here we can see, since in the figure, there is one diagram below. Here you can see there is increase in vaporization of the inhalation agent, that is sevoflurane, when there is a decrease in the ambient pressure. That means the concentration of the anesthetic agent will increase when there is a decrease in the ambient pressure. So instead of this 2%, now I am getting 4% of sevoflurane. So what happens to the partial pressure? The ambient pressure is 380 mmHg, and 4% of that will again give me 15.2 mmHg, that is equivalent to 1 Mach. So this happens with vaporizer, with variable bypass vaporizer, where it is exposed to the ambient pressure. So the summary is, in such type of vaporizer, for example, if you are using sevoflurane or isoflurane in variable bypass vaporizer, irrespective of the dial setting, you will be getting the same Mach value or same partial pressure as that of the sea level and a high altitude. So modern vaporizers like isoflurane, sevoflurane, which are agent-specific temperature compensated variable bypass, will generate the same concentration. But let's see the case of a desflurane vaporizer. So a Tech 6 vaporizer heats the desflurane to 39 degrees Celsius, and it's like a closed chamber. It will maintain the partial pressure of desflurane as same to atmospheric pressure irrespective of the altitude. So in turn, you are going to get only a fixed concentration of desflurane in the output. So what happens? When the ambient pressure is low, because of the same fixed concentration of desflurane, the partial pressure of desflurane will fall. So in the what I tend to say is, desflurane won't generate same Mach value with a particular setting at sea level and high altitude. So we have to adjust the dial setting manually. For example, if your desired percentage is 6%, you have to multiply it with 760 mm mercury divided by the barometric pressure of the particular altitude. Then that will give you how much percentage setting you have to keep in order to attain a desired percentage. I hope that is clear. Now, nitrous oxide, we already know it's a less potent agent, and the potency again will reduce with high altitude. And at around 5,000 feet, we can observe a 50% reduction in the analgesic effect of analgesic efficacy of nitrous oxide. And also, there is high chance of expansion in the air trap pockets during aeromedical evacuation. So it makes nitrous oxide an unfavorable agent for providing anesthesia in high altitudes. And also about gas analyzers, all oxygen analyzers, they respond to the partial pressure of oxygen. So if you have calibrated an oxygen analyzer or other gas analyzers in sea level, it's better, or you have to recalibrate it at the particular altitude. For example, if you expose the oxygen sensor to 21% at the barometric pressure in the sea level, if you again use the same thing, it will be showing a lower FiO, lower oxygen concentration. So again, you have to recalibrate all these gas analyzers at the particular altitude at which you are using it. So that finishes off the basic main challenges that we pose. Now let's move on to the pre-anesthetic assessment in high altitude conditions. So the main thing that we have to keep on mind is the hypobaric hypoxia and the compensatory changes related to the high altitude. First of all, we'll start with the history. So here, particularly, we have to see how much duration of stay the patient had at the current altitude, because acclimatization will take at least 3-4 days. So the recent arrival patients who just reached the higher altitude at less than 3 days, they are at a higher risk. And also, if the patient has a previous history of altitude-related illness, any history of cardiovascular or respiratory diseases, those patients are at higher risk. And also, you have to take a detailed medication history. Check for tachycardia, hypertension, tachypnea, because these are expected to be increased because of the sympathetic stimulation. Also check the oxygen saturation, see for any signs of pulmonary edema or bronchospasm, any signs of pulmonary hypertension. and also do a brief neurological examination to rule out acute mountain sickness or high altitude cerebral edema. And also, very importantly, you have to see the hydration status of the patient. The patient is expected to be dehydrated. Go for complete blood count always, because there are chances of polycythemia and hyperviscosity, especially in chronic dwellers. And it's better to get an ABG done in order to assess the PaO2 and PaCO2 and acid-base status. Check the electrolytes, and you can go for an X-ray to rule out any pulmonary congestion is there. And ECG and echo is warranted if any pulmonary hypertension or right heart strain or any cardiopulmonary disease is suspected. Other investigations can be done as required. And those patients at higher risk are those came within 3 days, those with any pre-existing cardiopulmonary disease, history of high altitude pulmonary edema or cerebral edema, and those with significant anemia or polycythemia. And this is a Lake-Lewis score that is used for diagnosing acute mountain sickness. If you have a headache with any combined score of more than 3 of these symptoms, you are diagnosed to have acute mountain sickness. So you can remember the name Lake-Lewis scoring system. And what are the optimization strategies before you take up the patient to an OT? So first and foremost thing is acclimatization. So if possible, delay the elective surgery until an adequate acclimatization happens for at least 3 to 5 days. And always supplement oxygen, because the SpO2 levels can be less. And if you can use pulmonary vasodilators or diuretics if pulmonary hypertension is suspected. Correction of anemia and dehydration is very important, and always remember to avoid sedatives like opioids, benzodiazepines, etc., because it puts the patient on risk of respiratory depression, and again they will go into more hypoxia. And just for the interest, these are the common oxygen delivery devices that can be used at like any particular altitude. It will be difficult to by heart these things, but we can just see like at moderate altitude, we can use a nasal cannula. High altitude, we can go for Venturi mask or high flow nasal cannula. At very high altitude, we can use NRBM or again high flow nasal cannula. And extreme altitudes, we use special oxygen delivery devices as used by our mountaineers, those who go for Mount Everest and all. Again, about monitoring, the standard SA monitoring should be employed. And we have to properly evaluate the oxygenation, the ventilation, circulation, and temperature monitoring is also very important. Let's see what are some of the difficulties that we might face while using some of the monitors. With pulse oximeter, there can be cold-induced vasoconstriction and poor peripheral perfusion can be there. Motion artifacts can be there because of shivering, and in snow-covered areas and all, the ambient light will interfere with the pulse oximetry. And we are not supposed to target a high SpO2 level as we do in the sea level, like 95 to 100%. At high altitude, we are expected to keep a SpO2 of 88 to 92%. Very high altitude, we have to keep around 85 to 90. And extreme altitude, we need to keep only 80 to 88% of SpO2. And capnography also, don't try to target for 35 to 45 mmHg. At high altitude, 28 to 35 mmHg of CO2 is recommended. So it's because of a respiratory compensation or tachypnea as a result of hypoxia. About ECG, the expected changes are tachycardia can be there, baseline heart rate will be elevated, arrhythmias are very common, and right heart strain patterns can be there because of the pulmonary artery hypertension. Other monitors like non-invasive BP, invasive BP can be non-invasive BP should be used. Invasive BP can be used according to the severity of case, and temperature monitoring is mandatory. And other advanced monitoring like CVP, transesophageal echo can be used if indicated. Now let's see what are the effects of the hypobaric hypoxia on anesthetic agents and muscle relaxants. So the MAC value of inhalational agents can be misleading at high altitude. So it's better to use BIS monitoring while we are using an inhalation agent. And as I told earlier, variable bypass vaporizers, they does not require any dose adjustment, but desflurane requires manual calculation, and we have to increase the dial setting. And nitrous oxide should be avoided preferably. And the clearance of propofol will be reduced and half-life will be prolonged. So we have to reduce the dose by around 20 to 20% for unacclimatized patients. And the induction is expected to be faster and recovery is expected to be prolonged. And also, if the person is a chronic resident of high altitude, there can be a paradoxical increase in the need of propofol. So the above mentioned features are for those who ascended recently. And also always use BIS monitoring for better titration. And ketamine is the agent of choice at high altitude because it maintains the hypoxic ventilatory drive. And it also maintains the cardiovascular stability. But again, in patients with cardiovascular instability or hypertension, again, it can aggravate the BP, and that can be more sympathetic stimulation. So again, that is another concern. Regarding muscle relaxants, if possible, it's better to go for a neuromuscular monitoring. And the onset can be slower in high altitude residents, and the duration can be potentially prolonged. All these are effects of the chronic hypoxia on these patients. And cisatracurium or atracurium is preferred because they are organ independent on elimination. And there is actually no proper consensus regarding which reversal agent to use. Both myopyrrolate, that means neostigmine, or even sugammadex can be used safely. So the use of pecuronium or rocuronium is also it is also safe to be used. Again, coming to the ventilation strategies, these are some of the ventilators like Hamilton T1, Impact 731. These are some of the ventilators that have the altitude or pressure compensation software. So preferably go for these ventilators if available. Otherwise, we can go for pressure targeted modes, and the ventilator should be recalibrated to the operating altitude. And also adjust the FiO2 appropriately. Don't go for very high FiO2. Try to taper the FiO2 to a lower value. So to summarize, the high altitude anesthesia, it poses various difficulties to the anesthetists because of the hypobaric hypoxia, all these pathophysiological changes, the technical constraints, all the changes in the machines and all. And all these machines, ventilator, they will function little differently at high altitude. So usually most of us are working at our sea level. So we are not that much acquainted with all these changes. So it's always better to have a very good knowledge about how the patients will behave, how the machines will behave before we provide anesthesia at a high altitude. I hope everyone understood the topic. Thank you.
A very thank you to Dr. Xavier. A very thank you to Dr. Xavier. Like the next, we are going to talk about practical management and critical care in high altitude setting. This will be presented by Professor Longjam Eshori, who is an experienced anesthesiologist in the Department of Anesthesiology, Regional Institute of Medical Sciences, Imphal. She has got so many cases. So like I would like to request Professor Longjam Eshori to go on for the topic. Please continue.
First of all, I would like to thank the ISA Puthukkottai branch for giving me this opportunity to speak on this. In special thanks to the Sir Dr. Meenakshi for giving me this platform to speak. And I would like to thank our head of department, Professor Dr.Gajendra Rajkumar, for giving me this opportunity to speak on this webinar. And also thank the organizers of this webinar. I would like to thank. And now moving on to the next topic, as we have in the last topic, the practical management and the critical care in high altitude settings. So this topic comprises of what are the objectives here in this topic? Like one is the perioperative management protocols. Then next is the obstetric trauma and critical care management at a high altitude, and about the management of the altitude-related medical emergencies. Next is the training and preparedness of the anesthesia teams. And lastly, the lessons from the military and expedition medicine. So regarding the perioperative management protocols, like some of the topics has been covered by the previous speaker, second speaker, but I'd just like to highlight how we go on for the perioperative management. As usual, like other patients, like pre-anesthetic checkup is a must for undergoing any operative surgery procedures. Like so, history this year slightly different from the others. Like as we have to find out whether the patient has been, whether it's a chronically stable, like the patient is staying in the high altitude from the before, or just come up to the is a highlanders. We call it highlanders. So we have to take a brief history and examination, because all the signs symptoms may be different from those chronic patients, like chronically dwellers. They have been already acclimatized to situations of the in the high altitude. But those patients who are coming just in the highland, just landed in the high altitude, maybe the symptoms of the, like we have to assess the symptoms of AMAs or the high altitude cerebral edema or cerebral pulmonary edema. This has to be ruled out. And moreover, then chronic mountain sickness, those who are residing like polycythemia, signs are there, or cyanosis, or clubbing, any sort of breathlessness or anything should take off. Then we have to evaluate the cardiopulmonary reserve, because that will be derangement can be there. Supposing if the patient has a cardiac problems from before, or stenting has been done recently before that in a few months, or maybe the patient has been in coronary bypass, any other, or patient has a history of COPD, respiratory other problems. So we need to evaluate further for cardiopulmonary reserve how much a patient works, functions. Then we have a brief investigation, like we do allow any polycythemia. We need to do the complete blood picture should be done, complete hemogramming. You have to take it, and if available, then you have to do the AVG analysis to know the status of the oxygenation, and even the bicarbonate levels we need to know bicarbonate. Then after that, chest X-ray should be ruled out. Any other pathophysiological based congestion or any other sorts of things are there. And echo ECG is also, it's not a mandatory for the echo, but ECG baseline should have been undertaken. Then we have to optimize the patient. Like we have to correct dehydration. Such type of patients, we expected that dehydration will be there because of the hyperventilation, as we know, and moreover there's cold diuresis, we know. So dehydration is present, then we have to correct it properly. Then acclimatization is not there. If it is a planned surgery, we can allow them to 3 to 5 days at least before the surgery. And treatment of the high altitude pulmonary edema, cerebral edema should be treated beforehand. You have to optimize it to the level, and control of polycythemia may be required. If needed, we need to go for the phlebotomy or the volume replacement if the hematocrit level is more than 65%. And one more important thing, psychological preparation. Why? Because early, like if the patient is land up in the recently, then because of loneliness, and the patient will be the situation may be different from the place. So maybe psychological preparation of the patient also a very necessary thing here. And regarding the pre-medication, like opioids and benzodiazepine can be used, but we have to be with caution, because post-operative, we have to think of the respiratory depression, prolonged recovery from the anesthesia, keeping it in mind, and we should use with caution. But the atropine and glycopyrrolate we usually use for the GA patients can be used safely as it is. And regarding the aspiration for prophylaxis also, you have to be, because we have been discussed about the delayed gastric time and the nausea, vomiting are more in such type of patients. So we have to aspiration prophylaxis is almost to be mandatory. Then what are the monitors in high altitudes? The same thing only, like pulse oximetry target about 88 to 92%, and NIBP should be there, and tachycardia to be ruled out, and then right ventricular heart strain pattern is there or not, arrhythmias is developed or not, should be monitored accordingly. Because if the cardiac problems are there, then the supraventricular tachycardias is very commonly seen intraoperatively. So we have to monitor any arrhythmias has been taken place or not. And capnography, as it is, we have to maintain about 28 to 35. And temperature, one of the hypothermia, which is very in the cold climate, we expect it to be, but with the intraoperatively also we can maintain with either we put warming or the blanket or any other sources. We have to use it to maintain the temperature about 21 to 22 to 24 degrees centigrade, so that in the post of the delayed recovery, which is one of the hypothermia being the cause, we have to take care of. Even the coagulating profiles may be, coagulopathy may be one of the factor, but the hypothermia takes place. So we have to take care of the temperature as well. Now, extended monitoring modalities, what we can have, if available, the central venous monitoring, pressure monitoring could be there, or transesophageal echocardiography and neuromuscular monitoring, because we have told that key, like, see the monitoring muscle relaxants, like other than this atracurium, cis atracurium, they can be delayed, prolonged action. So if it is a neuromuscular monitoring system is available, is well and good, and BIS monitoring, which is a very standard, like when you use the TIVA, like total intravenous venous anesthetic agents, then it BIS monitoring, which is very helpful to see the level of the depthness of the anesthesia, as well as supposing like overdose. Overdose is one thing because of the pharmacodynamic and pharmacokinetic changes altered in this cases of the high altitude. So we can prevent all those overdose side effects like delayed recovery, respiratory obstruction, all those things, or the prolonged stay in the OT, like that can be avoided if you use BIS monitoring. And another thing is the blood glucose, which underestimate the glucose level approximately 1 to 2% in 300 meters and suppose about 1,000 feet elevation, because it underrates, because the glucose, most of the sensors in the glucometer has been when glucose oxidase level sensors have been kept. But in this area, the level of the oxygen is lower. So that will be the falsely lower level of the glucose can be given. We found it. So we have to see the level, how much is the percentage, especially is patient with the diabetic patient or anything, we have to see and adjust the sensors accordingly. Nextly, we have inhalational agents. We have the previous speaker has already explained in detail. So only there we have the variable bypass, is no requirement adjustment. Desperate has manual calculation and dose increasing is required. And the nitrous oxide, as we have already told, there is no role in case if the about 5,000 feet, there is 50% reduction of the analgesic potency, and 10,000 feet above that, there is almost negligible. So there is no role. If you want to use it, then you have to adjust the dose requirement. Then ketamine, as we said, we know it is enough choice in the high altitudes because of the hypoxia drive is preserved. Moreover, that laryngopharyngeal reflexes is maintained using the ketamine, and propofol like is one of the good, but we have to consider reduction of the unclimatized patient because the hepatic clearance and renal clearance is reduced. So one of the factor that, and moreover, the CNS sensitivity of the propofol in case of the unclimatized patient. So another thing, but in case of the high altitude, patient residents who are paradoxically may increase a higher dose because the sensitivity has been acclimatized properly. There have been cardiac respiratory reserve has already been altered, so can be increased the paradoxically dose in the higher dose. For titration, we require BIS monitoring. Regarding the muscle relaxants, we have already spoken about this. Next is the BIS guided propofol in using the TIVA, using the closed loop anesthesia devices. This is one of the things, like studies has been also done, like using the BIS guided propofol infusion, clades maintain the stable depth of the anesthesia, BIS level within the plus minus obtained of target BIS 85% of the time, and hemodynamically very stable. Patient can back up within 3 minutes, and recovery can take place within the 15 minutes. So this is a proof safe, effective, and suitable for the high altitude or the resource limited setting. But the problem is the system is not available yet in most of the places right now. This is a picture I want to show that this sensor will be there, controller and effector, and the dose treatment will be given to the patient. If there is any patient is red is less, then we can sensor will give to the controller, then the output will increase. If it is more, if there is a layer because of the hemodynamically, if the patient become lower, then they can sensor will get and lower the dose. So this has been controlled by the monitor itself. So regarding the spinal anesthesia, which is very preferred over the general anesthesia, and an increase in the local anesthetic dose requirement has been observed in such types of high altitude patients, and incidence of post-dural puncture headache is also known. I'll be coming detail about this in the next later slides. So spinal anesthesia, one thing is that the onset of the blow was significantly longer, and the duration of the sensory and motor blow was significantly shorter in the spinal anesthesia performed at the moderately high altitude, especially in the chronic dwellers compared to the sea level that has been observed in some of the studies. But intraoperative management is like that we have to, if IO2 should be maintained, more than 50% is required. And here I want to highlight more the goal-directed fluid therapy. Why we need it? Because we should make the tissue perfusion and oxygen delivery system should be maintained when we give the fluids. because we do not want to overload, because already the patient has been chances of risk of pulmonary edema there. So we have to titrate the dose of fluids according to the patient needs. And hypothermia is another thing. We have to use the active warm devices, warm fluid, and maintain temperature as 21 to 24 degrees. Then post-operative care, we have to supplement oxygen until fully awake. This is a target and should have maintained a stable preoperative SpO2 level. Then regarding the pain management, we should avoid excessive opioids. If better, we maintain with the NSAIDs like ibuprofen or paracetamol. This is better because of the excessive opioid can again delay recovery. I will be there. And moreover, the hypoxic drive may be gone. So maintain normothermia, hydration necessary, and monitoring of other illnesses like AMAs and all, happy and HASI, whether it's developed or not in the post-operative period, we have to take care of. Now coming to the next subheading, like obstetric anesthesia in high altitude. Obstetric anesthesia, whether it's the sea level or in the high altitude, is unavoidable. So we need in the pregnancy, we all know that there is a reduction in the oxygen reserve and susceptible to hypoxia, like every pregnant patient. But when you go to the high altitude, these things are more pronounced and thereby leading to the poorer of the neurological outcomes is there. And moreover, they will alter the pharmacokinetics and hemodynamics in such patients. And they are in the high altitude, higher incidence of PDA, like patent ductal arteriosus and patent foramen ovales are high, incidence of ARDS, pulmonary hypertension in the neurons are high. So hypoxia, which has been exacerbated by pregnancy complications, can leading to preeclampsia or fetal growth restriction or retardation, or maybe the placenta-related growth disorders can be encountered. So like preoperatively, such type of obstetric patients, we have to, some extra things we have to rule out to assess any signs of pulmonary arterial hypertension. We expect that pulmonary arterial pressure will be right, leading to the pulmonary arterial hypertension due to the hypoxic pulmonary vasoconstriction. So we have to assess any pulmonary hypertension signs are there or not, or pregnancy-related complications like eclampsia or PIS, and to assess the BP, urine output, 24-hour urinary output, or any signs of end organ involvement is there, because we have to titrate the drugs as it is the altered pharmacodynamic and pharmacodynamics are there in pregnancy. Then given the reduced partial pressure of oxygen at altitude, aim for the higher maternal SpO2 and consider using the supplementary oxygen in the early period. Then moreover, intraoperatively, what else we have to do? We have to aim for the stable block, which minimizes the hemodynamic swings. To be prepared for hypotension, promptly we can intervene either the vasopressor or IV fluids, and if there is a increased blood loss which is expected, so if there is, then blood products should be available. Then maternal hypotension will compromise further the fetal oxygenation, especially in high altitude. So we have to be careful to avoid the maternal hypotension also. So technique of choice in this obstetric patients in high altitude should be the regional anesthesia, because it's in the risks of general anesthesia can be avoided, like airway problems, hypoxia, aspiration, which is amplified again in the altitude settings and can be avoided. And moreover, the altered drug pharmacokinetics and the changes is due to because of in the plasma volume, pH, and the CSA volume, which lead to the increased requirement the dose of the local anesthetic, especially in the chronic dwellers. So we have to do the fetal monitoring as well. Fetal oxygenation and is continuous fetal monitoring wherever it's available should continue, because the fetal outcome is poorer in such patients. Preparedness, not only the anesthesiologist, like we need in terms of high remote, often limited sources are there. So we should have a NICU, a capability of the NICU should be there, blood bank should be there, limited ICU beds. So we have to be, teams should be prepared. So anesthetic and obstetric team must have anticipate higher potential for maternal fetal complication. If then required, then transfer of the arrangement should be made. So post-operative care, oxygenation should be given, then we should be monitor also, then pain management should be avoided, the opioids, hydration. But one more thing is that the PTPS, post-dural puncture headache, which is seen in these patients are more intense. Why? One more thing is that atmospheric pressure drops, yes, the pressure drops. They increase the cerebral arterial blood flow, vasodilation, which increases intensity of the headache. And one is the dehydration, which is very common in such type of patient because of hyperventilation, a whole diuresis. So such type of patients with a post-dural puncture is had. So we should take care and prepare, and we have to post-operative monitoring is much required. Then coming to the general anesthesia, it's more challenging at high altitude due to the decrease in the functional residual capacity. And as it is, there is a lower PO2 is exists, hence the chances of the faster desaturation will be more. And risks of aspiration also more. So difficulties with analytical adjustment, vapor pressure changes, gas expansion when you use a nitrous oxide or anything. So you have to, that's why we prefer the regional anesthesia rather than the general anesthesia if it is feasible in just in high altitude pregnant patients. So coming to the anesthetic management for trauma at high altitude. Supposingly, like we have challenges in high altitude, we all know, because of the environmental factor, physiological factor, logistical factor, being a remote terrain, to get difficult access, delayed evacuation, limited monitoring equipment, inexperienced personnel. There will be cures because they are not been prepared for how when we have to deal with this type of patients. So anesthetic as unreliable vaporizer output, gas expansion in the cylinders, altered the pharmacokinetics. So trauma-related, like such type of patients, like see, imagine if there is a head trauma, head injury, chest, or long bone injuries, which are very common such of type of terrains, and there will be high risk of frostbite and crush injuries. Here, the role of anesthesiologist is very much, and we have to be trained how to tackle such type of situations. So our problem is to tackle with airway and ventilation, being an anesthesiologist. So during the airway management, we have the ventilation part, like supposing such type of patients, like to have to taken up for the ventilatory support, we have to have a rapid sequent induction because we suspect it is a full stomach, chances of aspirations high, and monitoring the end-tidal carbon dioxide because we want to avoid increase in the pulmonary vascular resistance, avoiding the hypercapnia, and even the saturation you have to closely monitor it. And FiO2 should be highly given because given the lower baseline PO2 is already low. Then blood and the coagulation factors, problems. So we have to warm the bloods, manage the coagulopathy early so that more further complications could be avoided. And you should be very aware of the keeping in mind polycythemia could be there, high hematocrit, then chronic altitude dwellers because increased viscosity that will again lead hemorrhage problem and make complicated resuscitation problems. So we should be think in mind when you give because blood and coagulation factors problems will may arise in such type of situations. So we have to warm fluids blankets when we have to access. If there is a trauma, we as usual we put IV bore accesses, equipment and vaporizer which are functioning well or not. At this altitude, calibration should be done. Then plan for the induction carefully. Then hemodynamic stability. But whenever possible, we have to regional blocks or nerve blocks. And we have noticed that in the nerve blocks, the dose of the local anesthetics does not change much. So if it is feasible for the limb surgeries and all, if possible, we try to do the regional anesthesia, like even the nerve blocks we can utilize to have the anesthesia for such type of trauma patients. Postoperative, as usual, we should be maintain normothermia. Early mobilization here, if possible, to reduce the risk of thromboembolism because of such polycythemic state, there is again the viscosity of the blood is increased, plasma volume is decreased, so there will be chances of thromboembolic phenomena which can again complicate in this type of situations. So coming to the critical management, this is also a part. So just see, hypoxia is already there in this situation. Oxygen delivery also already compromised. And the low basal and the line of the baseline of the PaO2. So there will be rapid dissociation with a small minor lung injury takes place. So there will be sudden dissociation, will be rapid dissociation will be there. And pulmonary hypertension and the right ventricular strain. Why? Because of the hypoxic pulmonary vasoconstriction, which worsens the pulmonary, increases again the pulmonary vasoconstriction. So what happened is worsen the right ventricular function and the strain to the right ventricular strain will be there. And fluid and hemodynamic changes will be there because there will be decreased plasma volume, increases viscosity, which will increase the cardiac output. Workload again. So you have to keep in mind while giving it fluids, hydration should be properly maintained. Then altered pharmacokinetics, hypoxia and poor perfusion, which can alter the drug action, which need a close monitoring. Then resource constraint, limited equipment will be there, monitoring evacuation will be difficult, so management will be very difficult in such type of situations. And altitude-related specific illnesses, high altitude pulmonary edema, high altitude cerebral edema can coexist in the ICU condition. So we have to manage the ICU problems other than we can complicate further while we have to manage such type of situation as well as the ICU management as a regular. So ICU management here, ventilative part, I would like to highlight here again, because are the ventilators we are using at the sea level, it has not been set, it's different. So use of the ventilators with a high altitude compensation software like Hamilton T1, Impact 731, this update for. And volume target pressure regulate targeted modes rather than the volume control, because the volume may not be delivered what we have said here. So pressure is a fixed one. So pressure targeted modes are preferred here. Then we have to recalibrate the ventilators to operating altitude. Then we have to adjust the apparatus upward. Then hemodynamic and the cardiac output should be monitored. So that use of vasopressor inotropes guided monitoring. So we should avoid tachycardia. Already the hypoxic state, the myocardial demand of the oxygen is high. So if there is tachycardia, again, there will be demand of the pulmonary cardiac load will be increased. Then ICU monitoring here, the SpO2 and a frequent FVC is required, and the right atrial pressure monitoring also, if available, is good and well. We have to monitor it. And renal monitoring, because of the hypoxic environment, there will be renal perfusion will be impaired. So we have to see the regular renal monitoring, like at least a simple this one urea creatinine or electrolytes should be monitored regularly, and neurological monitoring should be done to rule out like hypoxia, hypercapnia, or other related altitude-related ankylopathy, which can complicate the ICU course. Then sedation and analgesia we should be very careful. Excessive respiratory depression should not be happen to the patient, because with already compromised oxygenation and the ventilator reserve. So we have to adjust the physiology, altered physiology, and the drug dosing need to be adjusted throughout the course of the treatment. Regarding the nutrition ICU, so metabolism may alter at high altitude because of the higher basal metabolic rate. So nutritional support should be carefully managed, and because of the glycolysis takes place in the situations like so, the carbohydrate should be increased, protein should be increased, so because the higher basal metabolic rate be expected here. Then evacuation escalation plans should be done if remote high altitude setting, plan for the early evacuation, the patient deteriorates, and we have to coordinate with the referral centers at a lower altitude as possible, and ensure oxygen delivery systems are robust, backups for the cylinders or supply chain is available or not. So when we shift the patient with the unpressurized helicopter cabins act as open chambers, causing the rapid exposure to the reduced barometric pressure, and hypoxia without the time for acclimatization is again dangerous. So air containing the body cavities, pneumothorax and pneumoperitoneum, IV line tubing should be promptly decompressed for air rate. Now coming to the altitude-related medical emergencies, we have two things like acute mountain sickness, which is mildest form, and high altitude headache and acute mountain sickness. Onset starts about 2 to 12 hours after rapid ascent, that is more than 2,000 meter. Timing will be usually during and after the first night at altitude. Resolution will take place if it is a mild form, 12 to 48 hours, and no further ascent takes place. Then clinical features as it is headache, nausea, anorexia, vomiting, insomnia, and predisposing, especially if it is higher risks are there in females because of the progesterone effect, younger individuals because the demand of the oxygen demand is high, so that will be more of they are prone to have develop more. So improvement again occurs if there is descent of 300 meter, which is a diagnostic of the whole mark. And we have other differential diagnoses to rule out before this also. So we have to monitor with the pulse oximetry as we go to the, is it normal with the or slightly low. So diagnostic tool is a Lake-Lazy score. We have to see what treatment will be like oxygen therapy, 4 to 5 liters via the mouth, or oral acetazolamide, 250 milligram BD, or IV or IM dexamethasone will be administered, or for the headache and all, we can give ibuprofen and for nausea, vomiting, the ondansetron and adequate hydration. This is our supported treatments. Then coming to the acute high, this one altitude pulmonary edema, if this develops, this is not, which is when we have to think when the patient has acute pulmonary, not explained by the cardiac failure, especially if the new high altitude exposure. This typically occurs at 2 to 5 days after the rapid ascent, that is more than 2,500 meters, can appear earlier also in those predisposed patients. So diagnosis will be the clinical diagnosis in history of rapid ascent, symptoms are there, hypoxia is there, or no other signs of infection other than this one, high altitude. So investigation, we have to see the chest X-ray if available. Then the patchy alveolar infiltrate, which is usually the perihilar, asymmetrical batwing pattern, but non-cardiogenic. And we have to rule out the cardiogenic edema. For that, brain natriuretic peptide, if it is normal, then it's a favor of the acute pulmonary edema can be suspected. Then ABG, we have seen the hypoxemia with respiratory alkalosis may be encountered. The echo, we have to see normal LV function is there, then it should be, or elevated pulmonary artery pressure is there to rule out. For this, we have to see the echo. Definitely treatment management will be immediate descent, and this would be like descend with more than 500 to 1,000 meter in a single most effective intervention once you go down the sea high, descent will be takes place. But if the descent is not possible immediately, what we'll do is supplement oxygen. Pharmacologic therapy should take place, like the calcium channel blockers, nifedipine, or if it does not respond with the PDE inhibitors, we can like sildenafil. Then employ the portable hyperbaric chambers like gamma bag if available, or we can use the CPAP or NIB, significantly improves the outcome. This is the gamma bag which has been used to this one-man chamber, we call it, for using for the patient for the descent. If we cannot, suddenly we cannot bring down, then we can use it with the gamma bag. Then oxygen therapy at that present with a goal target of about SpO2 more than 90%, and flow rate about 4 to 6 liters, where the fixed marks is increased as needed. And in ICU setting, we should have high flow nasal cannula can be used, or non-invasive positive pressure ventilation or CPAP about 5 to 10 centimeter of water. These modalities improve oxygenation and reduce the pulmonary artery pressure, so the symptoms of pulmonary edema or congestion can be relieved. So these are the pharmacological treatments for this. Nifedipine is slow release, it decreases the pulmonary artery pressure, improve oxygenation. If it is first line, it's alternative again pulmonary vasodilator, sildenafil. Again, can give because decreases the pulmonary hypertension. And then we have dexamethasone or diuretics if there is suspected a clear overload to clear. Then acetazolamide again we can use it. And supportive care should be done like active warming, then minimal exertion, absolute bed rest, mechanical ventilation if required, lung protective strategies should be given, avoid hypercapnia because it can worsen the pulmonary vasoconstriction again, and we have to maintain about a high FiO2 with that above PO2 at least more than 60 millimeter of mercury. This is the mechanical strategy, ventilation requirement. Then evacuation, if no improvement within 6 to 12 hours, should be of oxygen, nifedipine, or oxygen descent. Then portable hyperbaric chambers, if available, we can use, and it can pressure equivalent to about 1,500 to 2,000 meter lower can stabilize until the descent occurs. This was also another source of treatment. Then prevention should be gradual ascent. Like if you ascend less than 300 to 500 meter, sleeping altitude again per day above then we can avoid such type of symptoms. So avoid overexertion, cold exposure, then prophylactic nifedipine we can use it, or the tadalafil may be considered for recurrent high altitude pulmonary edema, or in soldiers, mountaineers with a high exposure risks, they can be used as a prophylactic treatment also. Then now coming to the cerebral edema, high altitude cerebral edema, which is a life-threatening brain edema. Diagnosis can be made in the context of the recent ascent, and unlike the stroke or infection, high-altitude cerebral edema typically develops rapid ascent and reverses quickly with oxygen or descent. This is another typical thing like in this presentation. The imaging, if available, we can see diffuse cerebral edema if no focal lesion can be seen. Then management part will be immediate descent as usual, and delayed, there is a risk of death, or if that portable hyperbaric bag, if descent is impossible. Oxygen should be given, maintaining the SpO2 of 90 to 92%. High flow oxygen is a life-saving. Dexamethasone will continue, improve the cerebral edema, and symptoms rapidly should continue. It started and it should continue till the recovery of the signs and symptoms, like should continue 2 to 3 days. The supportive care like adequate rest, hydration, normothermia, monitor for the seizures if developed, or mechanical ventilation if indicated, then we have to intervene. And adjuncts we can say like acetazolamide, mannitol, hyperventilation, evacuation, and prevention should be always gradual ascent, and avoid alcohol sedatives, acetazolamide, starting 1 day before the ascent and continued for 2 to 3 days. Dexamethasone 4 milligram PD for high-risk individuals if required. These are the things for the preventing such type of symptoms. So training and preparedness. Why we need training and preparedness of anesthesia teams at high altitude? Because understanding the altitude physiology, like we have the previous two speakers have talked about the physiology and the pathophysiological challenges. So we have to understand very much detail how to prepare ourselves, the equipment, environmental preparedness. Then we have to conduct the simulation and the scenario-based training, like conduct simulation drills of altitude emergencies, equipment failure, or hypoxia management. We have to focus on the teamwork, rapid decision making, that crisis resource management skills should be aware. The emergency and high-risk case management should prepare for early identification of this management of the high-altitude emergencies. Emphasis should be given with conservative fleet management, monitoring of the pulmonary edema, and multidisciplinary collaborations, and continuous education is required to understand more how to deal with such type of situations. So lessons from the military and expedition medicine, what we learn. These key lessons like plan for osteophysiology, expect hypoxemia, polycythemia, pulmonary hypertension, preoperative stratification, and raise FiO2 targets, and prepare the environment kit, like we should have a portable oxygen backup, oxygen conserving devices, gamma or pressure bags, or ventilators, simple ventilators, portable ones. Then portable monitors should be available. Synchronized protocols and training should be done. Then prevention and early therapy should be like graded ascent, prophylaxis, acetazolamide, low threshold for oxygen, descent evacuation for AMS and Hashi and Happy, and adaptation of the anesthetic technique. Evacuation is a definite thing. Establish clear medevac routes and triggers you have to maintain. So this is how the military applications of hypoxic training of the high altitude take place. The US military acclimates units of the high altitude operations. There have been simulations, training programs has been conducting how to accommodate in such of terrains. Will be a very good training for the military people. So coming to the recent advances briefly, I would like to highlight here rehabilitation of the elderly and sedentary surgical patients by stationing them in a simulated high altitude environment with a reduced oxygen for a week resulted in the better surgical outcomes. So, and another newer drug, methazolamide, other than the acetazolamide, we commonly know is a methylated lipophilic acetazolamide analog. Besides inhibiting the anhydrase, it directly also activates the antioxidative nuclear factor, related factor 2, and also it blocks the interleukin 1 beta, this is one of the newer recently drug, which is very helpful to deal with such situations. So take home message is high altitude induces detrimental challenges in human physiology, and not other than this, you have to know the anesthetic equipment which warrants recalibration for proper functioning in such type of environments. So the choice of the anesthetic techniques would be the total intravenous anesthesia and regional anesthesia, which are the utmost and most practical options in such of high terrains and high altitudes, which is very helpful for our anesthesiologists and to know better about how the techniques of the takes place there. These are my references. But one more thing I want to say, the higher you climb, the clearer the perspectives, just as in medicine, the challenges elevate our understanding. Thank you all for sharing for this one.
Thank you very much, Dr. Longjam Eshori, for the very detailed and insightful topics. So, like, there's a question from Dr. Muthukumar Rajagapalan. Like, it is said that how do we treat high altitude pulmonary edema if it occurs pre-op? Then how do we identify high altitude cerebral edema pre-op? And then professional diagnosis for delayed recovery. Then is there any use of hyperbaric oxygen chamber at very high altitude in anesthetic or ICU setting? Like, sir, if I'm allowed to reply this thing, I would rather say that high altitude pulmonary edema is fatal in roughly 50% of the patient. So the only thing is that we have to give oxygen to the 4 liters per minute via oxygen masks or oxygen canister or utilizing a hyperbaric bag, that is gummo bag, if available. Then the only thing is that we have to make the patient, it is a rapid descent of the altitude. That is the only definitive therapy. Then regarding the high altitude cerebral edema, like it can be suspected at any patient in high altitude who show unexplained delayed recovery or neurological depression after anesthesia. So like it can be described adequate oxygenation, normal ventilation, and absence of residual anesthetic effect. Key features include altered sensorium, confusion, disorientation, irritability, severe headache, vomiting, and sometimes hallucination. Ataxia is a hallmark feature if the patient was ambulant preoperatively and now can walk straight or coordinate movement. So high altitude cerebral edema should be strongly suspected. Management includes administration of high flow oxygen, head elevation, and intravenous dexamethasone 8 mg IV followed by 4 mg every 6 hours, descend to a lower altitude if it is definitive, if it is possible, or if there is available of portable hyperbaric chamber may be used if descent is not immediately possible. Maintain hypothermia, pneumocapnia, and avoid fluid overload to prevent rise ICP. If there's a rise ICP, even people say that okay, we can use furosemide also. And sir, by the way, like I would like to emphasize that Imphal, that is the state capital of Manipur, is approximately 790 meters. So like we are not living in a high altitude environment, and because Manipur is approximately 970 meters above sea level. The city is located in a oval shaped valley like that. So like we have tried to collect so many articles and information from the articles regarding people staying in Tibet and Ladakh. So that's what we can collect it. I hope this will satisfy your answer. So like it is over to Sir A.L. Meenakshi Sundaram for giving us the chances to present this webinar. Thank you very much, sir. Sir, we're going to hear a voice.
Sir, please unmute yourself.
I thank all the 4 faculty for having explained in detail about anesthesia at high altitude. These senior residents, Dr. Jyolsna and Dr. Antony Xavier, have done very well. They are going to be the future Eshori madam and the future Gojen sir, I think. Dr. Eshori madam, former Jyolsna, and Dr. Gojen sir, former Antony Xavier. So they have done very well that these professors, 2 professors, they are training their students also to be good speakers. And they have described it very well, all these complications, expectations, physiological and pathophysiological adaptation, everything in detail and with clarity. And they have maintained the time also. So perfectly well conducted webinar. I thank all of you. Tomorrow I'll get back to you individually regarding the feedbacks we have received. Now I request Clarinet Swastika to offer the concluding remarks and conclude the session.
Okay, sir. So, thanks to all the dignitaries present here. Clarity is really glad to have all these brilliant people together in the session today, and I really hope that you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much, everyone, for joining with us.
Thank you.
Thank you, and good night.